So my name is Benedikt Schoser. I'm here one of the senior consultants at the Friedrich Bauer Institute in Munich. And the Friedrich Bauer Institute is a major referral center for neuromuscular disorders. And one of our topics, of course, is myotonic dystrophies. And myself, my whole professional life, I was very much interested in myotonic disorders and also myotonic dystrophies, all types, especially type 2. But today I will try to summarize and introduce all of you to both types of myotonic dystrophies. So the myotonic dystrophies are the most variant disorders you can think of. So therefore you have to deal with a multisystemic disorder. And I put here a concept on the slide I call the segmental progeroid diseases. So what is meant by this? By this is meant that the myotonic dystrophies have in all organs different signs of aging, of early aging, and that's really in the muscles, but also in the brain, but in the heart, as well as the gastrointestinal tract. So everything has a segmental progeroid disease element in it, and therefore it's a very interesting disorder to work on, but also therefore very challenging. So if we look at the epidemiology of myotonic dystrophy, if you look at both types, so worldwide the DM1, we say something about 5 to 12 in 100,000. There are some areas around the world, like the Quebec area in Canada, where we have 200 on 100,000. And in Germany, we have 10 in 100,000 inhabitants. That's what we know about epidemiology. If you look at DM2, so this is of course worldwide much rarer. So we guess that 1 in 100,000, but also there's some countries with a very distinct higher frequency like Finland. And in Germany, we have a very comparable situation with DM1 and DM2. So there's 10 for DM1 and also 10 for DM2 in about 100,000 inhabitants. If you look at the next step, so what is the clinical phenotype presentation? And if we put together all the different phenotypes we know, so we have pre-DM stages where you just have a cataract, that's all. Then the interim medium form of myotonic dystrophy type 2, and then the classic Steiner disease, DM1, and of course the most severe part is the congenital myotonic dystrophy, and that's related to the DM1 repeat. We don't see a congenital form in DM2. So let's talk about multisystemic involvement in both myotonic dystrophies. We have core elements. So of course there's the name-giving core element like myotonia, and of course the weakness and atrophy of the face, of the neck, of the finger, of axial muscles, but also then multisystemic symptoms like the cataracts, the cardiac conduction alterations, in part later on then the cardiomyopathy, the different types of cognitive dysfunction, hypersomnia, fatigue, hyper-GGT, the gallstones, the dysphagia, of course hypercycemia plays a role. We have in some of the patients insulin resistance and the testicular atrophy, the frontal balding and the hypogammaglobulinemia. And in some of the patients we see also the myalgia. There are a few items that are more specific for DM1 than DM2. So at the beginning, we have a prominent distal weakness and a distal muscle atrophy at the DM1 spectrum. And of course, we have the congenital form where the retardation is a big element, the hypertonia, the facial diplegia, and the tent-like mouth, something very typical for them, and also the gastrointestinal tract alterations. In DM2 at the beginning, it's definitely, and that was the former name, a prominent proximal weakness and proximal muscle atrophy. In some of the patients, in addition to this, they see calf hypertrophy and also restless leg syndromes. So this is really the overlapping, but also the distinct phenotypes of both diseases. DM1 more distal, DM2 more proximal, and a big overlap in the multisystemic involvement in both. To show you here some pictures, so this is really a picture of a congenital myotonic dystrophy case. You wouldn't guess his age. He's presently 28 at this picture taken at that time. He was 28, and you see this very prominent face of the person, the tent-like mouse, and then you see the distal atrophy on the legs, but also here on the arms. And here on this picture, you see the so-called anticipation. Of course, there's a severely affected mother, but you see here the kids are much more affected. So he was a late onset DM2 person, but the others two are the childhood or even then the congenital form of onset that is very classic to that disease. If we look at the survival in congenital myotonic dystrophy cases, so there's one of the really nice studies Campbell did, and that's published in 2004. If you just look at the days of ventilation after birth, so you see that the mortality rate, if you are prolonged ventilated over 30 days, is really becoming very high. Later on, it's declining. And if we look at the days later, new data, so there will be even a better outcome than in this former study. But anyhow, it's a high rate of mortality in the first year for this congenital form. So therefore, this is definitely the most severe form we can have in the myotonic dystrophy spectrum. And of course, I present you here the very classic standard disease phenotype. You have again the distal weakness of the arms, but also of the lower legs, and you see also an actual atrophy in those person. And later on, oh, I'm sorry, go back. And later on, you see the pronounced diplegia of the face, very common. And here you see another element in the later course of the disease, that also the ventilation, the respiration is limited. So therefore, sometimes you need artificial ventilation. And again, here, the very prominent distal weakness and atrophy of this person. If we look at the survival in DM1, so here we have two great cohorts that are published, so big cohorts from Canada, from the Quebec DM experts. And you see there was a follow-up of the same cohort. The first period was 10 years, and in the total 20% died. And after 25 years period, there were 27.4% death in that cohort. The mean age at that varied from the 10 years cohort from 53 to 56, and the most of them died to respiratory insufficiency, and also this was related mostly to infections. And of course, we have a lot, up to 20% of cardiovascular disease. Neoplasia plays a role, and also we have sudden death in that cohort, mostly related to cardiovascular disease. The mean age of that changed in the period from 10 to 25 years now for the childhood onset, from 44.7 to 48.5. For the classic adult onset, from 55.4 to 54. And for the very mild phenotype, so here we have a 10-year step in the long period. So you see that common elements like the standard of care, I will talk about this later, was really helpful to give a better outcome in those patients. But anyhow, still the life expectancy is greatly reduced in myotonic dystrophy type 1. If we look at myotonic dystrophy type 2, and hopefully that is moving, you see here a very classic patient. So this is really a later onset disease. So the core age is something about 40 to 45 to 50. And the most common complaint is that climbing a staircase or getting up from the floor, getting up out of a chair is becoming more and more difficult for most of the persons. Later on, they also develop a proximal weakness of their arms and the shoulder muscles as well. But most commonly, it's the iliopsoas paresis in those patients. So therefore, these are major neuromuscular complaints. Leg stiffness as a type of myotonia is also very present. And again, here you see a very nice work of Recommondations. They put together our data of our cohort that also here is a multisystemic involvement. You have cataracts in the most, you have gallstones, you have thyroid dysfunction in up to 30% of diabetes, and also affective disorders, and the cardiac disease is also a prominent feature of the multisystemic involvement. If you look at the long run, so that is really different to DM1, you see that only about 15% need a crutcher or a walker, and 9%, or even a wheelchair, up to 6% even in the long run. If you look at this, so therefore you can clear-cut say that the life expectancy in those patients is not reduced. It's in the normal range, with some exceptions if the cardiac topic is really in front. So what is the background? The background of the myotonic dystrophies is the repeat disorder, and here you see the both chromosomes locations. So in DM1 you have on chromosome 19 the repeat in the area of the DMPK gene. Normally in this area we do have something about 5 to 37 CTG repeats. In mild diseases the repeats go up to 200, and in severe diseases and even congenital it can go up to 400, but this is all on the blood DNA level. In the DM2, it's the zinc finger 9 gene, or CUGB binding protein gene, that is affected, and here we have on the 5 UTR stretch a CCTG repeat included, and normally we say that up to 37 CCTGs, it's in the normal range, and over 75 for sure, and very long stretches can be there, and you are diseased by a DM2. Both disorders are autosomal dominant transmitted diseases with a type of anticipation, but that is only found in DM1. You have here from generation to generation an earlier onset and a severe disease course. And the most common diagnostic still is the PCR, the long-range PCR and southern blotting, which I'd like to explain you next. So what we can do is really, and that's still gel-based and kindly given from Press to me. So here you see the classic DM1 southern blot with different types of repeats. Normally you first look for the normal alleles here in those patients, and here in addition you see already very long repeats. That's a completely normal person where you see both alleles, and here you see always only one allele and the others is already eliminated. And there's another one with a very small repeat. And if you then go for the real southern blotting with different enzyme cutting, then you see also congenital forms. So these are very long stretches in the repeat. And that is even more prominent if we go for Myotonic Dystrophy Type 2. So here normally you screen for the normal allele. That's the first test you are doing. And that's over here. And here you see already smaller alleles that are normal. But if you look at this, you definitely see that this is already as a long stretch of CCTGs. And here again, in addition, you see two normals, and that's why you need a long-range PCR system. And still, this is one of the big troubles, that even our latest NGS technologies, the PacBio, is not completely tackling this perfect, these very long stretches of repeats. So therefore, you still need this type of technique to really overcome the burden. And so therefore, my real guess is that DM2 is absolutely underdiagnosed in many countries, because this technique is not done in all labs. Even in Germany, where we have this high frequency of DM2, it's not given in all labs that they can perform this in the best way. So we need very specialized labs to do this. And here again, you see the normals and the diseased allele here, also very long stretches again. And that's very important for making the diagnostic step. So what is our current understanding of DM1 and DM2 on the level of pathogenesis? Of course, we know since many years that this is a nuclear mRNA export alteration. We have an accumulation of mutant transcripts in the myonuclei, and they play a dominant negative toxic RNA transacting mutation effect. The most common hypothesis that is best proven is that this all causes a spliceopathy, and this at least contributes to 70% to the disease. And what is this spliceopathy doing? It's the mutation affects the alternative splicing of multiple genes. And on top of this, we see that also DNA hypermethylation may play a role here, and the altered RNA metabolism is very important. And one of the classic readouts we have in our myoblasts and all cells we can stain is really the CUG here repeat in the myonuclei. And you can use either a FISH technology, but also you can use a specific antibody to visualize this perfectly. So let's go a bit more in detail. So what is this toxic RNA gain of function model really saying? So here you have the different types of DM1 and DM2 locus on the gene again. But let's focus a bit more here on the ribonuclear foci with the mutant RNA. And on these long stretches on repeat, here is the recruitment of really these blocked splice factors, and one of them is the muscleblind 1. We have also 2 and 3 for different parts of the body, and they are stuck here in the long repeat elements and recruited, and that's really what you can here see in the cell, that muscleblind stained foci are here, and the splice factor normally that should be active to splice in a normal pattern is blocked and cannot work. And in addition to muscleblind 1, who might be the really most important of it, but there's also CUG binding protein 1, and also 2 others, or at least 2 others, who also play a very important role. So what do we know about alternative splice defects, which are very good detected? We know pretty well, and I'll show you this later, for the chloride splicing, for the myotonia. We know since many years that the insulin resistance is caused by a splice defect in the insulin receptor, but also cardiac arrhythmias can lead back to the sodium channel alternative splicing. And also for the dystrophy, we found out in the last years that there are different types of genes alternative spliced, and therefore causing the dystrophic part of the disease. In addition to this, there's also nowadays a discussion on, is there a GSK3 beta pathway in myotonic dystrophy? Is that highly active? Because we know that the GSK beta reduction is seen after CUG repeats, and we have a correction of this. And of course, there's the cyclin D3 activity is going up, so that we have a more active CUG binding protein, and this finally should lead to a correction of the DM1 pathology. So therefore, there's a treatment effect with small molecule inhibitors to the GSK3 beta that is already under the way. So this is an alternative extra pathway that is of interest, and we will see if this really comes to reality for our patients and leads to a positive effect. So what is, going back to the alternative splicing, here more on the GOCB binding protein and especially on the muscleblind proteins related. So one of the core features is myotonia. And of course, this is the classic clinical picture, is the decontraction inhibition in the fist opening. So the fist opening is slowed, is stiff, is weak. And we notice pretty well that this is really part of the myotonia. And we can do this with the electric excitability is increased in those fibers. And here you see the classic myotonic stretch. So the chloride channel stays prolonged open, and that's here in the wild type, the normal signal, and here in the mice, the very prolonged opening. And in addition to this, you see these long stretches of myotonic runs in the patient, and that is related directly to an imperfect splice element. Normally, you should have this type of element, so that would be the full length, the normal chloride channel, what an adult person as in the muscular. But in myotonic dystrophy type 1 and 2, you have these inclusions of exon 7A and exon 6B that cause CLC1 loss of function and are attributed to the clinical myotonia we see. And even if you look at the staining, so normally you can stain the chloride channel very nicely here with a monoclonal antibody, and in both there's only very few channels you can visualize, and normally it's completely absent, and that's also based on this modification into an embryonic type form for the gel. So this is one of the best examples now, really since many years studied, and is used as a major readout in many clinical trials. They will come or even already started. For the myotonic muscular dystrophy part, so we have here some new elements. So just a few years ago, the Paris myotonic dystrophy working group could very nicely show that splice misregulation of the dystrophin, and here after one of the last exons, exon 78, leads to dystrophic changes, what we see in the musculature. So that is a classic picture. So that is a very classic picture of myotonic dystrophy. So you have more internalized nuclei, you have the so-called pycnotic bags of where you just see some of the nuclei and hardly any muscle tissue left on this, and you have ungulated fibers, very classic. And here, this is a very classic finding of sarcoplasmic masses and so-called ring fibers here on this direction. And this is perfectly in line what is found with this special exon splicing in the dystrophin gene, that was very nicely presented. And here on the plot, you see the inclusion and exclusion that was found in the cDNA of myotonic dystrophy patients and muscle tissue. So this was very helpful. And there was another very interesting finding really by skipping the exon 11 in the BIN1 gene that leads to a T-tubulus alteration, and that also results in the muscle weakness of the patients. So here in controls, that's the normal set line, and you see the very normal orientation of the sarcomeric structures. And here there is the T-tubular system, more specific staining. You can see that. And in DM1, you see there's a loss of this, there's a widening of the tubular system. Here again, you see it clear cut, so that would be the normal size of the T-tubular, and here you see a much more pronounced T-tubular system. And even if we go to the congenital form, you see that on top, you see here changes of mitochondria, but also the completely loss of the tubular structure, and also Z-line streaming is very important. So therefore, we have this irregular and longitudinal orientated T-tubular system that results in the muscle weakness of myotonic dystrophy type 1 and the congenital form at least. On top of this, we see different splicing of so-called myofibrillar genes and proteins. So therefore, the myofibrillar myopathies really in a way display similar changes, and we see protein complexes and misfolding. We see stress granules in DM1 and DM2 pathology with the activation of the proteasome pathway and also mitochondrial alterations. Therefore, there's a high display of different types of muscle degeneration in those samples we know from DM1 and DM2, and they all in summary lead to the muscle weakness, but also as the chloride channel to the myotonia, and really as the base of our disease. So what can we say about the heart in myotonic dystrophy type 1? So we have very good registries from the US, but also from the French registry, and you see here really the big numbers. So there are 406 and 855 adults, and even in the most of them, the CGT expansion size is at least from blood known, and we have follow-up times of 9.2 compared to 11.5 years. And in that period, In the French registry, 210 patients died, and of them 32 suddenly, and in the US registry we have 118 patients died, and also here we have at least some of them with a clear cardiac cause. Others have more complaint rates about the neuromuscular respiratory failure rate in those patients. If we look in more detail for what is ongoing on the cardiac side, so you see it's more clear that the conduction system is altered. So this also calls for the ion channel as the troublemaker here. So you have supraventricular arrhythmias, but also ventricular tachyarrhythmias, and even patients with permanent pacemaker are a high number, but also a pacemaker is not completely abolishing deaths in the cohorts. So the regression analysis told us from the French registry that larger CTG expansion are highly significant associated with total deaths, sudden deaths, and pacemaker implantation, and that was very well reflected also in the US registry. Very important. So what do we know about the heart in DM2? What we can say finally, the frequency and the severity of cardiac involvement is very similar but reduced in DM2, and the progression is slower and less severe. But also here we have a comparison of an Italian-German cohort. So there were 102 DM2 patients and 170 DM1 patients. We were all monitored with similar devices, and the mean follow-up for DM2 was 7.4 years and 5.7 for DM1. And the results, 10% of the DM2 persons, versus 31% of the DM1 persons had a prolonged PR interval, and 17 versus 48 had a very long QRS complex. So that is a very important marker for the disease, and only 6 DM versus 28 DM1 patients required a pacemaker or defibrillator implemented. So therefore there's some differences, and it's reduced in DM2, but it's comparable. The progression is slower and less severe. Again, here I can show you that aberrant splicing in DM1 heart tissue is the causing mechanism. So there are different channels altered, but the most prominent is the SCN5A. Here, a special inclusion of exon 6A leads to the change of the cardiac alteration and heart rhythm system, and that is very nicely shown here for different channels. But here you see the control, that's it. And here you see the clear-cut change of the 6A inclusion in DM1, and that causes really a lot of the cardiac conduction system alterations we know in DM1. And also some new data show that this is a prominent cause for DM2 as well. So therefore, spliceopathy also here is really a proven topic. Of course, one of the most interesting issues of this multisystemic disease is what do we know about the brain, and can brain imaging help us? So you will see that there are already plenty of small studies were performed over time in these cohorts. So it started rather early, so that was really with the start of MRI studies and also some CT studies, that we see a global cerebral atrophy with dilated ventricles in the most of the patients. We see a gray matter loss in the frontal, parietal, occipital regions, but also in the superior and mediotemporal gyrus, and also thalamic and basal ganglion structures are affected. If we look at the white matter in the whole brain in DM1 and DM2, we have changes in the association fibers, the commissural fibers, but also of projections to the brainstem and the internal and external capsules. There's a connection deficit between the prefrontal and temporal cortical areas, and also we know that there's alteration of the longitudinal fasciculus and cingulus, very important for those patients. And finally, we have an increase in functional connectivity in the bilateral posterior cingulate and left patellar deformal network. So that was also in additional studies now well presented. If we go in other images, we see that we have, of course, the white matter lesions in the frontal area. So that is the most common and prominent finding you can see in the most of the DM1 and DM2 patients. Of course, then we have, in addition, lesions in the anterior temporal lobe. That is also, as you see here, the bundle of data set that really points that out. And we have another thing that is very important. There seems to be a familiar aggregation of these findings, and they do correlate in a way with disease progression and also with CTG length. But here again, you have to think of that the length is always the length of the blood, and in tissue we know it's much longer. The repeat stretches are much longer compared to the bloodstream. So therefore, we need additional information to better understand this. Of course, there were also done some other metabolic investigations. We know that there's a hyperperfusion and a change in the glucose metabolism in frontal and temporal lobes. So this was a long-term finding. And in addition to this, there were very nicely done works on the Minerop and Kornblum group from Bonn. So that was the first and the second paper that's out now. So the same cohort of DM1 and DM2 patients were investigated at 2 time points in a distance of 5 years, and they clearly could show that they have a decline in gray and white matter tissue and a decline in connectivity. But the most interesting thing was that the change over time was not really heavily progressive as we sometimes thought. So this leads more to the discussion that we don't have a dementia type or degenerative type of brain disease. So it could be more a neurodevelopmental disorder that is really the cause of the brain disease in DM1, but also in DM2. So what is behind that? Also here we have very nice work done by Nicolas Sergent from France, who did a lot of work on this, and we know from the few cases who were done with a new state-of-the-art neuropathology investigation in those patients and those brains, so that we see a lot of so-called tauopathy. So this means in a way that also here we see different differentially spliced tau aggregates in the brain of DM1 but also of DM2. And if you want to go here more in details, I still recommend also, it's now 5 years old. This is very good review of the whole pathology and our current understanding of what is ongoing in the brain in DM1 and DM2. Changing gears, so what can we do as clinicians with a multisystemic disorder like this? Of course, we can do a lot already for those patients. And before I go into some of the modern treatments, we still have to really think about the easy things. So the most easiest one is, of course, the cataracts. So that is a very old technique, and surgery has, of course, also made some good progress, but this is something that is clearly easy to perform. In a very few patients, you will also need surgery for the ptosis. But this is not that common, but also some centers do this more frequent than the others. For me, the most important part, and that's really what I hopefully pointed out to you, is the cardiac diagnostic workup. You need to have at least once a year an Holter EGZ and also an echo, and then always discuss at later ages, do we need a pacemaker or a defibrillator in those patients? This is always something you have to discuss with your cardiologist, with your whole team up, that is needed for this type of disorder. And especially if you have the chance to have a so-called invasive electrophysiology workup. So sometimes this is the only way to really learn what is ongoing in your patients. So cardiac monitoring is most important in all of your patients, because the cardiac death, similar to the ventilatory insufficiency, that is the most likelihood why your patient will die earlier. So therefore you have to think, do I have to implement a non-invasive ventilation or not? Or do I have to follow up with the lung functions every year? So that is very important in your consideration of your daily treatment of people living with myotonic dystrophies. If we look for the gastrointestinal tract, also here you definitely have to look for gallstones, but also there's motility disorders, so a lot of things ongoing, and you always in DM1, in less extent also DM2 patients, you have to ask, are there any complaints in your gastrointestinal tract? Still, the cornerstone of all treatment is for both types of myotonic dystrophies is definitely the physiotherapy and the occupational therapy. Both is very important, especially in DM1. Think about the losing the capability of your hand functions, and therefore here also occupational therapy is very important. Of course, we have talked about the brain disorder. The brain disorder is sometimes reflected also in a psychiatric disorder. So you have mood disturbances, you have changes in the behavior, you have changes of the cognitive part. So therefore, sometimes you need cognitive behavioral therapy. I will go to that later. And also antidepressives are sometimes helpful in those patients. An issue not completely solved is the use of antimyotonic treatment. In my eyes, I think we need to explore this further. In DM1, there is a need to explore this further, but also in DM2. Here's perhaps the hidden myotonia, I call it always, that is more important, that the people are not capable walking fast, that are capable to climb a staircase very well. And this is not related sometimes to the just weakness and atrophy of the muscle, but it's also related to definitely the myotonia in those patients in the lower legs. Antidiabetic treatment at the really standard, and metformin is a very good one for starting. And of course, you have to correct any type of endocrine insufficiency, especially if it's a hyperthyreosis, because hyperthyreosis will turn your myotonia into more neuron, so therefore you have to do this better. For the daytime sleepiness, the fatigue, so beyond the cognitive behavioral treatment, also modafinil is still helpful. And in DM2, but also in DM1, myalgia is a topic. And here gabapentin is perhaps one of the drugs you can start with, but sometimes you need to test a lot of different drugs before you find the right thing. If we look more into the future, so what could be our treatment strategies for myotonic dystrophy? And here's a wonderful review paper cited for you from Charles Thornton's group. And Charles put together what do we need and where we have to go to, and unfortunately also what we don't know. So one of the most promising things we can do, and that is really in development, and hopefully we see this really very fast as a clinical trial next year, is that we look for post-transcriptional silencing with antisense oligonucleotides that really tackle the long repeat stretches, that we can liberate the bound muscle-blind proteins, so that we can then finally have a normal splicing pattern in those patients. You know, there was already a first study that was unfortunately negative, but new oligos are under investigation, and hopefully we will find a very nice one that is helping the patients, and we have then a liberation of muscle blind again. Of course, then we have other parts. There are small molecules, of course, that could be helpful. And of course, targeting downstream RNA toxicity is also something that is very good. And of course, the other more upstream things would be transcriptional silencing. So you could also go for an RNA-mediated type of disease treatment. And all these types are under investigation, of course, in the scientific world, but also now in pharma industry, and that is very helpful to partner with them in the long run. So if we go from a top-down approach, of course, DMP genome editing strategies would be also very interesting, and there are different types of papers out. So I just put here one on spot because it was one of the first dealing with that aspect from the Nijmegen group from Rick Wansig and B. Moringa. They really looked for CRISPR-Cas approach for the instability in Myotonic Dystrophy Type 1 locus, and they clearly could show that the complete precise excision of the DM1 repeat from normal and large expanded DMPK alleles by this CRISPR-Cas approach. The removal of the repeat was without detrimental effects on the expression of genes in the DM1 locus. Very important because that was always a threat. And the myogenic capacity, osmotic distribution, and abnormal RNA protein behavior of transcripts were normalized, and I think that is a very important thing. But still, we need a lot more knowledge on really how to use this type of technique in a clinical setting, so that will need much more experiments and preclinical data sets before we are going with that into clinical reality. So in total, we can say we have, of course, different types of options, and the most promising is definitely the antisense oligonucleotides we are using here to really deliberate the muscle-blind or also the COG binding protein, and then the sidestep GSK3 beta inhibitors might also be helpful, but this has to be further proven. I think very important. But also there's some new things on the block. So Guillaume Bazet did a wonderful first clinical trial with something very common and very easy to use and very cheap to use treatment. That was metformin in patients with myotonic dystrophy. And he started with 40 patients. Final readout after 1 year was 23 patients. So metformin is, of course, used as an antidiabetic drug, but also we know that metformin can, at least in an animal model, influence the splicing of different genes. So therefore, this was the rationale to do this clinical trial. And in those 33 patients, and 9 of them were in the metformin group, they had in the primary readout, that's a 6-minute walk test, had a surplus of 32.9 meters compared to the really normal results of nearly unchanged in the placebo group. So therefore, this is very important, very interesting clinical trial as a phase 1-2 study in a way, and it would be interesting to see in a larger cohort if really that is stable. Especially if you have to think that 32.9 meters is rather similar what was given in the late onset Pompe disease study with the licensing finally of Myozyme, very similar readout, and so therefore this is really a good result for the patients. Very interesting study. And of course what we did together as a European group was an observational prolonged trial in myotonic dystrophy type 1 to improve stamina, a target identification collaboration, and here we, as the incremental impact and income of all the patients in their impaired health status is the fatigue of the patients. So therefore we tackled here the fatigue, and we, as a readout, went for DM1 active and activity monitoring devices in 2 groups, and they had 24 weeks of physical training in comparison to the cognitive behavioral therapy to tackle fatigue. So this was established and harmonized CBT intervention in 4 European countries. It was 2 arms, as I told you, randomized here. We have a total inclusion of 255 patients. That was very good. And they all got, if they were randomized to CBT groups, CBT on over 10 months in 10 to 14 sessions. That was really the key readout of this clinical study. And here you see the outcome. We definitely could show that the primary endpoint, a patient-reported outcome scale, very specific for myotonic dystrophy type 1, showed a positive improvement in the cognitive behavioral treatment compared to the standard care. But this is really a high positive result we had here for our primary outcome. But interestingly, all secondary endpoints were also positive, especially here. If you are less fatigued, you can walk longer distances. Here in our study, it was 26.5 meters difference, so it was an 8% change in the 6-minute walking test. Normally, you all will know in a 6-minute walking test, you walk 600 meter maximum normally to most of the patients. And this is very interesting to see that even with the cognitive behavioral treatment, if you are less fatigued, have a better 6-minute walk test. And also a lot of other types of secondary outcomes we monitored between baseline and month 10 and even prolonged to months 18 showed positive. We were very much interested in the accelerometry of patients, and here you could see that the 6 most active hours improved. And also here we have a complete positive result for those 2 outcome measures where we really over 14 days monitored the daily activity of our patients. And also the FDSS, the fatigue score and cis fatigue score also were positive. Of course, that's not really a surprise. So therefore a lot of interesting information came out. I finally come to things that is very important for a standard of care in those patients. So we have now for myotonic dystrophies type 1 and 2, but also for congenital myotonic dystrophies, the so-called harmonized international standard of care recommendations. They are published last year and also this year for DM2. And you see here different things as this flow chart, what is recommended by a group of experts around the world, really for monitoring, but also this includes what is the standard of treatment presently for all these different types of symptoms. And the wonderful thing is that you can download this now in very different languages, and you can really go to the website of www.myotonic.org. They have all the different types of languages, and of course the standard papers on the back. So here you will have a lot of good information for your patients, and I highly recommend to read those because a lot of experts put a lot of brains in that those are really good and will stay hopefully for a while. And of course then we have to update them. So that's all what I'd like to tell you today in this webinar. So this was the first webinar for myself, so hopefully it was not too boring to you, and thanks of course to the international cooperation partners and also here to my institute and the colleagues at the institute. This is the Friedrich Bauer Institute. I thank you a lot, and feel free now. We can have another 10 to 15 minutes for extra questions, whatever you like to tackle me. Thank you.
Thanks a lot, Benedikt. If anyone has any questions, please feel free to raise their hands or add it into the chat section. Everybody's quiet.
Fall asleep, that's it.
No, I don't think so. What I would say is, and I like this to the chat as well, is that if anybody wants to revisit this webinar, we'll make it available on the website very shortly. So it's always good to maybe review it because it was very comprehensive. I don't understand all of it being a web developer, but it was to me it was enthralling. So thank you very much. Last chance for questions, everyone. Can you see that, Benedikt? Any recommendations to treat I can't even say it, temporomandibular dysfunction?
Oh yes, this is a difficult question. So
it's a difficult word.
It's a difficult word as well. I would recommend to tackle about this the Gothenburg Myotonic Dystrophy group. They do work on this. They might be the best one. Really, you should write them an email and ask them what is their present recommendation. I'm not an expert in that. I'm very sorry to tell you.
That's great. Any more questions, anyone? I think it's quiet.
Yeah.
That's great. Thank you once again for all your time and trouble and everything, basically. That's great. I'll stop the recording now. And as I say, I'll make it available in the next few days.
Thank you.
Thanks very much.
Have a nice day.
You too. Take care. Bye.
Take care. Bye.